I'm Rebecca Lawton, and I'm the director of the Yorkshire and Humber Collaboration for Patient Safety Research. And I'm absolutely delighted to be able to welcome Ian Leistikow today to present on value-driven regulation of health and care quality in the Netherlands. I've been following Ian's work for probably about 15 years now, and he's written extensively about regulation in healthcare, about patient involvement in healthcare, and how we should more effectively and collaboratively be regulating healthcare organisations. And so I'm really delighted that he's taken the time today to come and speak to us about some of his recent work in this area. Ian is an inspector and advisor at the Dutch Health and Youth Care Inspectorate, and at the same time is professor at Erasmus University in Rotterdam, where he conducts research and supervises research into governmental regulation of health and care quality. He's a non-practicing physician, and in 2011, Ian became member of the Programme Advisory Committee of the International Forum on Quality and Safety in Healthcare, a conference, an organisation that many of us attend and are members of. And Ian's also a board member of SINC, which is an international collaboration of European health and care regulators. So he is an absolute expert in this area across Europe. And as an academic, Ian teaches and publishes about patient safety and the role of regulation. And he's published a book back in 2017, actually, on prevention being better than cure, which is about learning from adverse events. And if you haven't already done so, I would very strongly recommend a paper that Ian wrote, I think probably about 13 years ago now, with the title Patient Safety is a Tough Nut to Crack. So if you haven't read that one, it certainly inspired me and some of the work that I did, and I would strongly recommend that, along with many of Ian's other publications. Before I hand over to Ian, just a couple of housekeeping comments, please. If people could turn their mics off, cameras on is absolutely fine. Although please note that this session is being recorded and will be posted on the Yorkshire Quality and Safety Research Group YQSR YouTube channel, so you can view it afterwards, and you can also direct colleagues to go and have a look at it there. We are recording this, so please keep your microphones off. If you do have any questions, what we prefer you to do is not to put your hand up and ask them during the presentation, but if you could just pop them in chat, we will pick them up at the end, and we'll ask them of Ian then, and we'll make sure those questions are raised. Okay, so without further ado then, thank you again, Ian, for coming along to talk to us today, and I would like to hand over to you for your presentation. Thank you, Ian.
Thank you very much. Thank you, Rebecca, for your kind words. Okay, now we just practice with sharing my screen, which should work. There we go. Yeah, so hi everybody, my name is Ian. I'm coming to you from Utrecht, the Netherlands, which is right in the center of the Netherlands. It's actually sunny today, so that's nice. And I'm in my home, and this is a poster on my wall. So this is not the view that I have out from my window. It's Lake Como in Italy, and I put out that poster when we started working online during COVID, because I thought then people have something nice to look at instead of my head when they're video calling with me. So anyway, as Rebecca said, I have two jobs simultaneously at the Healthcare Inspectorate and at the university, which is an honor because I can combine research with practice that way. What I will talk to you about is the concept of value-driven regulation. I'll give an example, then I'll go through a couple of research phases that we went through regarding engaging patients or users in adverse event investigations, and I'll end with summing up the research program that we are currently doing within the Dutch Health and Youth Care Inspectorate, because we have a research program, a small research program within the Inspectorate. That will be just brief, but then if you have any interests in any of these research projects, you can reach out to me and we can connect. So that's the idea of my presentation. All right. Yeah, so in Roman times, when the emperor would have a triumphal parade through Rome, there would be a slave standing behind him with a laurel wreath over his head, saying, "You are only human, you are only human." So 2000 years ago, we already knew that people in power can lose touch of reality. And I feel that this is one of the roles that a regulator has. Certainly in healthcare, but probably in all regulatory fields, we regulate people, but also companies, institutions that have a lot of power and that do things, that should be doing good things for people with less power, patients, users, families, etc. And to keep that power balance, to kind of have checks and balances for that power balance, I think the regulator has a big role. So this is one of the reasons why I decided to join the regulator. And as some of my doctor friends said, turn over to the dark side, as they sometimes have a bit of a negative picture of what regulation is. I believe regulation is something very positive, and it helps to create societal value. At least it should. And often it doesn't. And that is one of the reasons why we investigate what we do and do research on it to see if we can do it better. Just to give you a quick overview, the Dutch Health and Youth Care Inspectorate is basically a little bit like the CQC and the GMC and all the other professional regulators that you have in England. So we have them combined. So we oversee, monitor, regulate both healthcare professionals and organizations in all sectors of healthcare: public health, acute care, primary care, also manufacturers and distributors of laboratories. So that's the NIHR, I believe, in your country. Also youth care, long-term care. So that's a lot of different sectors and a lot of different laws and a lot of different types of regulations that we oversee. About 2 years ago, we published an article describing value-driven regulation. In that article, we had a different graph picture than we have in this slide, because we kind of worked on it further, also within the Dutch Health and Youth Care Inspectorate. And our goal was to really find a way to keep the eye on the ball, being societal value. So to find a way to help our inspectors to develop policy and strategies that keep societal value at the forefront. That is our goal, because what happens in every regulator, maybe every company, every organization, is at some point you organize stuff, and then the way you work kind of becomes your goal, instead of what you set up to have impact on. So that's why we built this. So basically it starts with societal value that translates into an issue. What is it exactly that you want to impact as a regulator? Then you have to gather intelligence and interpret that intelligence and develop an intervention. Then you do your intervention. Then you evaluate the effect or the impact of that evaluation using, again, intelligence and interpreting that intelligence. And that should have impact on the issue. And if it does not, then you need to change your intervention. And if it does, then at some point you might be able to stop your intervention. And all the time you have to keep in mind, is my impact on the issue also positively impacting the societal value that we wanted to have an effect on? And I will give you a concrete example. So I'll run you through this slide because it looks like a chaos, but we'll start in the upper left corner. So if you say as a societal value, and maybe this is not the right wording, but if you say patients receive the right care in hospitals, that is a societal value. We as a society value the idea that when patients come to the hospitals, that they receive the care they should be receiving. then you will understand that that is a very, very broad theme. So there's no way you could impact that with a strategy because it's just too big. So if you want to show your societal value, you need to make this smaller into something that you can actually impact as a regulator. That's the issue. So at some point, many years ago, we chose as an issue that hospitals should comply to the stroke guideline. Now, this is an old example, but I'm showing it because I have some nice graphs that can show you the impact of what we did. So basically what we had is we had meetings with medical specialist societies, so the Society for Surgery, the Society for, in this case, the Society for Neurology, and they said, you know, we have this guideline for stroke that you have to give thrombolysis within 1 hour, but it's very difficult to get people to comply to the guideline. So we thought, okay, let's make this a national indicator, and then we will gather information about the door-to-needle time, so the time it takes to give thrombolysis to the patient. And the guideline is you should do that within 1 hour. So just for the people without a medical background, if you have a stroke, you have a little blood clot in a vein in your brain. That means that everything behind that blood clot does not get oxygen anymore, and that's not good. And the neurologists say time is brain, so you need to take that blood clot away so the blood streams again and gives oxygen to that part of the brain. And one way of taking that blood clot away is by thrombolysis. So you inject something into a patient that takes away the blood clot, and then the brain is okay again. And you have to do that really quick, because the longer you take to do that, the more brain damage will occur. I hope that's enough explanation for the non-medical people in a minute, in a brief time. Okay, so we did that as a quality indicator. We published the data. We had meetings with boards members about, you know, this is you, and in regards to the other hospitals, how do you think you're doing? Could you be improving? And again, we then looked at the door-to-needle time to see if it was improving. Now, I have to tell you, we did this many years ago before we had the concept of value-driven regulation. So this, the way I fit it into the model is with hindsight. But the idea, I think, fits, this example fits the idea of value-driven regulation. So I'll show you some graphs now. So every dot here is a hospital. And the vertical line is the percentage of patients that got thrombolysis within 1 hour. So the percentage of patients that got the type of care that we planned to give them. As a society said, this is what we want. And the horizontal line is the number of patients. So you see a lonely dot here that I don't know if you can see my mouse, probably not. Oh, you can? Okay, good. So this is a hospital. It had treated 75 patients. And about 40% of those patients got thrombolysis within 1 hour. So that's not great. And basically, if you look at it, we say in Dutch, there's a schot hagel. It's a shot of, I don't know, like with your hunting rifle. Is it hail? I don't know what it's called. It's when you shoot with a hunting rifle, you have all these little pieces of lead going out. Well, that's what this looks like. And basically, you're delivered to the gods when you have a stroke in 2008, because the hospital you are sent to by the ambulance has a huge impact on your survival rate and your morbidity rate. So this is 2008 when we started this, and I will go through a couple of years. Sorry, wrong way. Yeah, 8, 9, 10, 11, 12. So here you see that in 4 years' time, we improve the average of about 65% to 90%. And more important maybe, you see that the average score of 2008, so these hospitals would say, well, we're doing pretty well because we're average, is actually 4 years later the lowest score of the hospitals. So it kind of proves that within pretty quick time, a short time, you can up the whole country, the whole nation in quality if you focus on something specific. And in this case, also have a good collaboration between the regulator and the professional societies who came up with this issue. They said, we want to change this. So this is an example of impact that you can have as a regulator. And this is one of the reasons why I really love my job. And I think we're doing some great stuff. But of course, I'm showing you a good example. I could have shown you a lot of bad examples of graphs that do not show impact, or interviews with people who say this really does not help. So there's a lot of themes out there that we could certainly improve on. This one is a nice one, and it shows you how value-driven regulation could work. Okay. So in that value-driven regulation model, you see the issue, the center bubble. And the center bubble is basically contains three elements. It contains the regulatory object. That is the translation of societal value into something concrete that we want to change, a gap between what we see and what we would like to see. We want to close that gap. That is the regulatory object. So in this case, it was the door-to-needle time for people with stroke. The standard is the professional standard or the guideline or the law that applies to this situation. And the addressee is the actor that we address as a regulator to say, you need to abide to the standard so we can attain that regulatory object. And we call that addressee and not regulatee, because an addressee can be more than just a regulatee. So the regulatee is the actor that we have a regulatory relationship with, a hospital, a pharmacist. But an addressee could be, for example, the healthcare insurance company in the Netherlands, or a town council, or some other party that has impact on how our regulatees, our healthcare providers, are able to provide care. So this is also one of the insights that we had. We said we shouldn't just focus on our regulatees. We should look at why our regulatees not able to create the quality of care that we think is important. What other actors are influencing our regulatees, and could we influence those actors to create the context in which our regulatees can deliver the care that we want them to deliver. Does this still make sense? Okay, and otherwise we have time for questions at the end. So regulating healthcare quality is all about the question, who is doing what to create which societal value? Who, the addressee, what, the standard, the regulatory object, the societal value. So basically, if you can answer the question, who should be doing what to create which societal value, then regulation is pretty straightforward, because you go to that actor, you say, are you doing it? No, you should be doing it, or what do you need to be doing it, etc. But life isn't always that easy. So more and more, we are confronted with situations in which the who, the what, or the which societal value isn't clear to us. For example, the selling of illegal pharmaceuticals through internet. We do not know who is doing that. And even if we did know, it's a website, and it's probably somewhere on the Bahamas, so we don't have any influence on it. The question of if two hospitals merge, is that good or bad for the care quality? We know who we should be talking to, the hospital board. We don't know what the standards should be for that, or which society value exactly we should be aiming for. So there's tons of examples of situations where the regulator can't really, use the classic compliance-based regulation models, which are really, for which you need to know who should be doing what to create which society value. And one of these themes is how patients, users, are involved in adverse event investigations. So what I want to do with you now is walk through a couple of research projects that we've done in the past, and end with one that was published last year, to show you how our development as a regulator in trying to understand the issue of engaging patients in adverse event investigations. And for that, it's, I think, good to know that in the Netherlands, it is mandatory for all healthcare organizations to report serious adverse events to us within 3 days. If they do not comply to that and we find out, we can give them a fine. and we can have a whole hour discussion on the usefulness of that fine, but this is the case. So they need to report it to us, and we give them about 8 weeks to do an investigation. They can take longer if they want longer. They can ask for more time. They do the serious adverse event investigation, the analysis. They send that analysis report to us, and we then judge the quality of that analysis report. So that's how it's organized now in the Netherlands, and how it has been organized for quite some time. And at some point we said, we should shift our focus from the content of the adverse event to the learning process in the wake of the adverse event. So when I joined the inspectorate about 13 years ago, we would ask content-based questions. So what was the blood pressure of the patient? Why did you give this medication and not that medication? Did the nurse have the right training? Stuff like that. And we decided, okay, this isn't really working because we're getting answers which don't answer the question we really have. And we should switch from the content to the process. How are they learning? Do they have a multidisciplinary team? Are they using a certain specific analysis method like root cause analysis? Have they engaged the right people? Are they engaging the patient? And do they have peer support? And does the board of directors do something with the outcome of this investigation? There's these questions that we judge. So one of the questions there was, are you engaging patients in your sentinel event or serious adverse event analysis? So this is the first publication in a row. This is 2016 in BMJ Quality and Safety, and one citation is, since 2013, the IGZ, that was how we were called then, has been pushing hospitals to engage the patient or a patient representative in sentinel event analysis. So sentinel event means serious adverse event. This provides the IGZ with an external check on the report's validity, in the sense that if the patient is engaged, the patient will also check whether this is valid, what the hospital is doing. But it might also increase the hospital's unease, because they have to be open with the patient about what happened and what they're learning from it. So this aspect deserves further research. So here you see the classic researcher ending. More research is needed. So since 2013, we said to the hospitals, you need to engage patients. And we saw that because we receive all these reports, these analysis reports. And if there was no note of a patient being engaged, we sent a letter back to the hospital, said you need to engage the patient next time for this and this reason. And if by the third time they still didn't do it, we went over there and told them they should be doing this. And you have to know we have quite some, potentially we have a lot of power. So hospitals do tend to, at some point, do what we tell them to do. Otherwise they get into trouble. So this was 2016. We also looked at how patients were engaged in mental health adverse events, which are often suicides, unfortunately. And we looked into how our patients and families engaged in the analysis of the suicide. And we saw that the respondents, so people that were interviewed for this study, argue that involving patients and families is valuable to help deal with the event emotionally, provide additional information, and prevent escalation. In practice, involvement consists mostly of providing aftercare and sharing information about the event by providers. So basically, this means that when a patient commits suicide, of course, they tell the family, but they don't engage the family in the whole analysis. And at the end, they provide aftercare. So how are you doing? Is everything okay? And this is what we analyze, etc. And what they also said was that family were often not involved in the care for patients in the mental health institutions, and they would rather be involved in the care in the first place, and then it would be natural to also be involved in serious adverse events like a suicide. But if you're only involved on once the patient has committed suicide, it's kind of too late for the family. So this was an investigation specifically in mental health. The other was hospitals. So we continue with hospitals now. And here you see the graph of the percentage of hospital adverse event reports stating that patients or family were engaged in the incident investigation. And you see that when we started in 2013, that was less than 20%. And the red line is the percentage of that it was clear that they were not engaged. And in some cases it wasn't clear. So that's the blue line. And there's a gray line of not applicable, in the sense that some events don't have patients, so that those are more technical kind of things that went wrong. So what we saw is once we started telling hospitals you need to engage patients, you saw an enormous increase, and basically within 2-3 years it was 80%. It was the norm to engage patients, which you could frame as a successful regulatory intervention. But you are all researchers, so you all have tons of questions when you see graphs like this, and so you should. We went out and did some more research, and Josje Kok interviewed, I think, 13 hospitals about how then is this done? So how are patients involved, and what kind of challenges are hospitals facing when they involve them? And a citation is: family involvement in incident investigations is typically organized as a one-time interview event. Interviews with patients or their families were considered to be valuable and important in their own right, and seen as a way to do justice to the individual needs of the patient or their family. Yet the usefulness and validity of the patient or family perspective for incident investigation was often seen to be limited. So they often spoke to them once, said, well, it's useful to speak to them because it's a way to do justice to their needs, they feel heard, but basically what they're telling me isn't really of added value. And what we also saw is that if the doctor says something happened at 12 o'clock and the patient said, no, it happened at 12:30, then the report will say it happened at 12 o'clock, because the doctor's version of the story is given more validity than the patient's. So this led to more research. And this is like a sidestep. Together with a historian, I looked at how patients are involved in patient safety, and how that how you can compare that to how patients are involved in healthcare, and the interest for this came actually because my mother is a nurse, or she was, yeah, she's alive, but she doesn't practice as a nurse anymore. So she worked as a nurse, and when she was taught to become a nurse, when she was in nursing school in the end of the 1960s, nurses were not told that the patient had cancer. And the patients weren't told that they had cancer. So basically the patient didn't know what he had, and even the nurse didn't know, and everybody was okay with that. And so in the 50 years since my mother was a nurse, and now we saw that first the patients weren't told what their disease was at all, then they were told, then they were kind of given, but they were told what, and this is how we're going to treat it. Then they were given a choice in the treatment, they were given informed consent. And now with many healthcare situations, it's about what matters to you instead of what matters. What's the matter? I mean, so what matters to you instead of what is the matter? And you kind of see the same development in patient safety. When I was studying medicine, we weren't even told something went wrong, and we certainly didn't tell the patients. We said, yeah, well, this is an allergic reaction when we gave too much medication or something like that. Not out of bad will, but probably because of awkwardness, or we didn't know what to do with it. At some point, we started telling patients that stuff went wrong, but we will do the investigation for you. Then at some point we start engaging patients in that investigation, giving them a choice, and maybe in the future we should be asking them what is important for you in regard to this event that went wrong and that has such an impact on you, instead of that we as a healthcare sector decide how to go about this. So this article kind of describes these two developments, which I see a lot of parallels in. But we went on. Oh yeah, and this is a large research which is published in Dutch, unfortunately, but there is a publication in English which I'll show in a moment, in which we looked at, okay, this whole incident investigation. Why are we doing this? Why are we regulating adverse events at all? How did it start? What was the plan? How's it working out for us? And this is a big report, 100 pages, commissioned by us. With the question, does the regulation of serious adverse events work out? And basically, I mean, of course, not doing justice to the report by summarizing it in one sentence, but basically it said, yes, it has had a lot of impact, but now it's losing its impact because the effect is kind of plateauing, and you should be asking new questions, new things. So this is one of the articles that came out of this study. And in 2020, it said the IRS, the incident reporting system. So that's the system in which hospitals have to report to the regulator, and the regulator does something with that report. The incident reporting system contributed to the increased involvement of patients and families, as you saw on the graph earlier. But involving patients and families in sentinel event investigations is not the same as learning from them. While patients and family members are increasingly involved, their input is not always valued by the investigators, as we discussed earlier. And that led to more questions. And this is a 2022 publication about epistemic injustice. So at some point, we came across the term epistemic injustice, and we thought, wow, this kind of fits what we're struggling with. And in this article, Josje describes, despite initiatives to facilitate inclusiveness, research shows that embracing and learning from diverse perspectives is difficult. Rather than repeat calls to involve more and listen better, we encourage policymakers to be mindful of and address the structures that can cause epistemic injustice. So in this article, we describe the structures that can cause epistemic injustice. So for example, because the regulator says the investigation has to be completed in 8 weeks, sometimes it's difficult to engage the family because the family isn't ready to talk about the adverse event within those 8 weeks because they're still trying to get a grip of the fact that their loved one has passed. Because we say a committee should be doing this investigation, the hospital makes a committee, mostly of doctors, senior people, and these senior people interview junior people who have been involved in an incident, and these junior people don't feel comfortable to really tell them what was going on, or if they do, these senior people don't really understand what they're trying to say because they don't emphasize and understand well enough what a junior person is going through in the daily work. So the structures can, even though people really want to do right and want to do well, the structures, the way we organize these kind of investigations can create epistemic injustice. So, and I'm nearly at the end of my presentation now. So last year we said, okay, so here we have a couple of problems. We're really trying to get the hospitals to engage patients and all healthcare providers, but just focusing on hospitals here, engage patients in serious adverse event analysis. We see that they're doing that more. We see a beautiful graph, but actually when we look behind the graph, we see a lot of problems. We see epistemic injustice. We see people being listened to but not heard. People being included at the end of the whole process instead of at the beginning. So how now are hospitals doing this? So we asked NIVO, which is a research institute in the Netherlands, to investigate that. The question of how do hospitals involve patients and families in the aftermath of a serious adverse event. And there we saw a very broad range of ways they do this. They all involve patients. Mostly because they have to, because we told them to. But they all feel that it's useful once they started doing it. But the way they involve it is at the one end, they tell them something went wrong, we're going to investigate it, and 2 months later they invite them to share the report. Say, this is our investigation report, you can read it in this room, there's going to be somebody standing behind you to make sure you're not taking any pictures of it. And then you can leave again and good luck. to the other end that they tell them something went wrong, so we're going to do an investigation and we would really like to involve you. What do you need to be involved in this investigation? And what questions do you have? And what would you like us to look into when we investigate this? And involve them all the way, and at the end give them the report either in the version that the hospital makes, or make a better readable version for patients or their families. So that's the broad spectrum basically of how hospitals deal with this now. And interestingly enough, in this research, they concluded that there was added value of the patient's perspective in these adverse event analysis. Well, earlier research said, no, we don't really see added value. Here, they did see added value. So something has changed over the years that in that perspective. So regulating healthcare quality is about who's doing what to create which societal value. This is the big challenge we have as a regulator, to find out what it is, to make this as explicit as possible, because only if we make this explicit, we can see if we as a regulator are having the impact that we want to have. Then one more slide, just to quickly go through what kind of research are we doing now. We're looking into geographical influence on quality. So we have a couple of islands out of the coast of the Netherlands, and they have general practitioners, and they have a very different working situation than on the mainland. So we're looking into how come, what do they and what do the patients on those islands feel is important with regard to quality of care. We're looking at learning and improvement capability of organizations. What does that consist of, and how could we impact that? We're looking at the interplay of regulation and criminology. So sometimes people in healthcare do stuff that's really bad, and that we have to talk with the public prosecutor about. And where do we draw the line, and how does it work out? We look into leadership's behavior on the impact on care quality. We look at appreciation of nurses. How are they appreciated, and how do they feel appreciated in their work? Sustainable employability is a big issue in the Netherlands, as it is, I think, in very many countries. So what do, in this case, doctors need to stay fit and employable in their job, and how could we as a regulator impact that positively? Reflexive regulation is a big theme in our research program. The safety science and incident investigation is something new. We're trying to see if we include more safety science perspectives, does that improve what we get out of incident investigation? The legitimacy of standards. And just before the meeting, we talked to this briefly. We look at what makes a professional standard legitimate or not, and that is because there are now people standing up saying we are also a professional society, and making standards that other doctors would frown upon. And we are looking into regulating the unexpected, as I'm calling it now. So how can we help healthcare providers anticipate the unanticipatable? Like we had a pandemic, and now everybody's looking at how can we make sure that the next pandemic we will be prepared. But of course, the next big disruptive thing will probably not be a pandemic. So how can we help healthcare providers cope with that, and also what is our own role? Then, for you who are interested in this, know that you are welcome to join us at the Erasmus SINC Scientific Symposium. This is a very small conference, max 40 people. We are now 30 people signed up, a little over 30 people. It's free of charge. And it's on Wednesday, June 5th in Utrecht, which is a beautiful city. I live there, so I'm a bit biased. And if you want to sign up, the PowerPoint will be sent to you after this lecture, and on the PowerPoint there's a link, and you can sign up. And if you have any questions, feel free to contact me. Right, thank you very much. Back to you, Rebecca.
Thank you so much, Ian. What a fantastic talk, and I would strongly recommend Utrecht as a city to visit. So so please do think about going along to the events that Ian advertised there. I'm sure there are going to be lots of questions. I have a few, and really appreciate the time you've taken, Ian, to run through a really broad kind of overview of a number of really important issues in healthcare, how to regulate, how to involve patients, how to learn better from incidents and adverse events investigations. So you covered a lot of territory there. So thank you for that. Do we have any questions?
I think Jenny's got her hand up there, Rebecca.
Yeah, sorry, I'm on spotlight, so I can't see the people who are in the room, but I can see Jenny's hand there. Jenny, over to you.
Thank you, and that's a really fantastic presentation, brilliantly clear, and it covered a lot of ground, but with depth as well. So thank you. I don't know if I'm allowed two questions. I'll pick my favourite first, and then if I'm allowed to ask a second question, I'd like to ask that as well, please. So looking at the serious incident investigation example, I suppose you yourself brought it back to the situation with mental health and people taking their own lives, and the point that you made about the families are rarely involved in the care of patients while they're alive. So I would take a step further and really, I suppose my question really is, when people themselves are rarely involved in their own care within the hospital prior to an event, and the default is to not be involved, then how do we transition over to post events to encourage their involvement? So is the answer to being able to fully support involvement post event to be able to involve them more clearly pre-event?
Yeah, Jenny, thank you for your compliments and your question. I totally agree. I think that would really help. I think if you normalize involvement of people within their healthcare process, then it's also normal to involve them when stuff goes wrong. And if you start involving them when something's gone wrong, you're kind of 2-0 behind in football terms, because you need to create a relationship first. And you don't have that relationship yet then, or you don't have the kind of relationship you need to do the, yeah, I think the interaction needed to collaborate on learning from an adverse event is a very different one than the interaction needed to collaborate in someone's healthcare. So if you don't involve people properly in that healthcare, then it's even more difficult to involve them properly in adverse event investigations, I would think.
Thank you. Yeah. Can I ask my second question?
Yeah, sure.
Sorry, Rebecca. So obviously what you've been doing is plotting and tracking and gathering intelligence about the extent to which patients have been involved in serious incident investigation. Have you been able to link that up at all to rates of litigation?
Yeah, that's I understand. The answer is no, and that is also because we don't have the data on litigation, but the data that is out there. So most data on, yeah, you have two kinds of litigation basically. You have the litigation in that you go to the insurance company and say, I want money. And you have the litigation, but maybe that's not the English word. Litigation is that you go to a judge and say, I want these people punished. The insurance companies, they say that mostly the people who come to us are the people who feel they are not heard, they're not listened to. And I can relate to that. So the people that escalate up to the healthcare inspectorate, so patients or family that escalate to the healthcare inspectorate and say, you should be going out there and doing something about this, are people who do not feel heard, mostly. So it's more a communication problem than it is a medical issue. So knowing this, the Dutch, not the healthcare insurance, but the insurance companies that you go to if you want to get money from somebody. I don't know what the English word is for that, but like the claims insurance company. they made, together with lawyers and healthcare providers and patient representatives, they made a document saying this is how you should go about when something goes wrong. And they say you have to be open to the patient, you have to tell them the truth, and this is very much in contrast to the belief of many healthcare professionals that they believe that they can't be open because then the claims insurance company won't pay out. But the claims insurance companies in Holland have made this document said you have to be open, because if you're not open, we get into more trouble. That's not what they write in there. That's basically their point. It costs us more money if you're not open than if you are open. And they even have it, it's a Dutch document, but they have some English words in it. They say don't beat around the bush with patients, because they have, and here comes a well-tuned bullshit receptor. And so just tell them the truth. So I don't see the direct connection between our data and claims data, litigation data, but this is what I do know. So I think there is a relationship in engaging patients in the right way, listening to them, and reducing the chances of claims or other court cases.
Thank you, Ian. I'm going to ask a question that picks up on Isabel's question, and Jenny's first question takes it a little bit further, and then I'm going to come to Jane O'Hara because she's been doing a lot of work in this area, so I'm sure she's got a number of questions she wants to ask, and then Jamila and Jane Moran, and we'll see if we can ask any questions beyond that, but maybe not. So you talked extensively about involving patients and families in investigations. And within the structure of regulation that you have, which is kind of values-based regulation, I got to thinking that some patients, of course, are much more willing and able to be involved in incident investigations than others.
Yep.
And could we end up with a system where the health service is being regulated by those patients who are willing and able to speak up and be involved in incident investigations, and then the voice of others who are less willing and able to speak up gets lost in that regulatory process? And I was interested to try and understand what you thought some of the unintended consequences of involving patients and perhaps not doing that very effectively might be.
Yeah, that's an excellent question. I would think that I will give two answers to this. One is for the investigation of the adverse events. I don't think this problem would rise, because basically this is a one-off event related to one patient or one family, and they either decide to be engaged or not. I mean, they have to be invited to be engaged and empowered to be engaged, but if they decide not to, then that's fine. But that decision will not be influenced by other patients who have a louder voice, I think. That's part one. Part two is you would want to not just involve patients when stuff goes wrong, but you'd want to somehow involve them in the whole policy and structure of patient safety within an organization. And there, I think your point resonates, because there you have to, I think, be very careful about who you engage and how you empower them, because there I can imagine you have the people with a loud voice that kind of claim all the space and not give the people with lesser voice a space. And for us as a regulator, this is a really challenging theme, because we see that the people who complain to us are the people with they can find us, they understand Dutch. They're mostly white people who have lived in the Netherlands for all their life, and there's a lot of people in our society which do not have the possibility or the knowledge or the guts to escalate to the inspectorate. So that's something we struggle with. How do we get those voices heard? Absolutely, and we don't have an answer for that one yet, Rebecca.
Thanks, Ian. Moving on to Jane. Thank you.
Rebecca, predictably put my hand up there. That was a great talk, thank you. And Jenny has asked a couple of really important questions there, I think, particularly one around the sort of assumed link to litigation. Myself and some colleagues on this call have been doing some work within the NHS England setting, trying to improve patients and family involvement in serious incident investigations, and done a large piece of work on that. And mostly it's focused at the sort of level of supporting individual investigators to do it. But what we saw when we actually tested those new processes, that much of what the struggles were not about sort of getting people's hearts and minds, you know, signed up to doing this. Actually, what they saw was very quickly they started to have problems doing those processes and engaging people in real, meaningful ways within the sort of rigid systems within organisations, but also those things then that are influenced by outside agencies like the regulators.
Yep.
So I suppose my question is about, you know, is there a risk? It's a double-edged sword, isn't it? So regulation can both promote activity, as you saw in your lovely graph, and that you know that the number that people are being involved is going up. But is there a risk for regulators, or how do we deal with the risk for regulators, for regulation more generally, that we don't just create sort of a tick box exercise where organisations say that they're doing things, but actually the real structural change that needs to happen isn't happening?
Yeah, no, absolutely. That's so that's the whole who's doing what for which society value. So and the graph shows that hospitals engage patients, but not how they are engaging patients. So one of the things that we saw is when the graph gets to 80%, we should have changed our question and not asked, are you involving patients, but how are you involving patients? And that would have been qualitative data. Mm-hmm. So this is quantitative data, it's a yes or no. But with qualitative data, you find out that there's a whole bandwidth of how they're doing this. And if well, if I could go back in time, so if we would have asked that question from 2018 forwards, how are you involving patients? Then at some point we would have gotten a sense of, okay, this I think is good, this is less good. And then you could switch again to say, okay, are you involving patients at the beginning of the process, for example? Or are you asking patients how they would like to be involved at the beginning of the process? So I think as a regulator, to quote Uncle Sam from Spider-Man, with great power comes great responsibility. I think your question is spot on, Jen, because the way we ask the question has an enormous impact on how healthcare providers act. And so if we ask it wrong, or if it can be interpreted the wrong way, we can actually increase the burden or increase harm even, instead of decreasing it or improving care. So this is absolutely one of our struggles. So I would say, once you see that they are being involved, then you should be asking how are they being involved, and at some point you should organize something to create a standard of some sort on how patients should be involved. And that standard, whatever format it would be, I would imagine, would be largely would exist largely out of empowering the people and giving them the choice how they want to be involved and what the goal of the adverse event investigation would be for them. Does that answer your question?
Yes, thank you.
Thanks so much, Ian. I'm going to come to Jamila now.
I think mine overlap quite a bit with James, actually. So I've got a conflict of interest. I'm a clinician, and I'm very new to patient safety, so I don't know the evidence base. I'm not steeped in it, but I think one thing that really struck me is if the regulators have so much power, actually, and they're so effective, what is the evidence base around the potential harm they can do?
Yeah.
What's the evidence base on how they are involving the public in determining what this regulation is? Because I think there was a lot of focus on how institutions do that, rightly so, but I just wondered if the regulators are so powerful and so important, what the evidence base around that is.
Yeah, so that's a painful question. Because, well, I'm very happy that people like Jane and people around the world are doing research into regulation, but there's not much proof of the added value of regulation. There is some, and there is also quite some research showing that it has no impact, and there's also quite some research showing that it has a negative impact. And I know from my practice, I can give multiple examples of all three. So I absolutely feel, but that's also, of course, my job. So I'm preaching to the choir, and I guess you guys are joining this webinar because you're interested in this theme. I feel there should be more research on the impact the regulation has and on how regulation can create societal value instead of a bureaucratic burden, etc. And I do feel that CQC is doing good work on this too. So just to do a little shout out to my English colleagues. It's not all bad out there. We are really trying to find out what it is that makes us worthwhile. And yeah, but it's a pretty young research field, certainly in healthcare.
Thank you, Ian and Janelle, for asking the question. Jane Moran, I think this will be the final question because we've got just 2 minutes. So Jane, you're finishing us off. Thank you.
Oh, okay, thank you. No pressure. Thanks, Ian, for that. I really enjoyed that. Having been a senior sort of nurse manager in the past, I've been involved in a lot of these kind of situations, investigations, trying to do the right thing, involve families, involve patients, get everybody round the table, as it were, to try and find out what was at the bottom of what happened. And I think it is quite a threatening thing for everybody involved. And as you've already alluded to, clinicians that get involved in these situations, they do find it very difficult to be open and honest, and they do feel like they're laying themselves open to difficult consequences by admitting to certain things or just being honest.
Yep.
And it really affects in one particular example I can think of, the family came away feeling a lot worse than they had prior to that meeting, just because of the demeanour of this person, because he was quite threatened, and and it was hard to explain to them, well, actually it's quite difficult for him as well. And I just wondered if you'd been involved in any kind of, I know it's probably an acknowledged thing, but is there any training or intervention that anyone's ever tested, to work with clinicians to make that a better experience for them and for everybody to be able to make that a worthwhile experience?
Yeah, no, absolutely there is. And I know of Dutch initiatives in this. I mean, that's not of much help to you, but absolutely. So you could either, so there's like the whole organization culture change thing that you say, we have to be open because we're learning from this and we're not blaming anybody, and they have to like experience that is true, because only one person has to have the experience that it's not true, and that kind of seeps through the organization, and years later people are still talking about it. And there's the just on time training that is also being done here in the Netherlands. There's this company, it's not a commercial company, but like a company that helps hospitals or other healthcare providers do this. So when a doctor or a healthcare professional is involved in a serious adverse event and is going to talk to the family or the next of kin or the patient, then they get a quick just-in-time training on how to do this. Because they realize exactly where your point. So that these healthcare professionals also have all these emotions. And people just react differently to stress. And some people, they make a mess out of it. And they don't mean to, but it's the emotions, and maybe they're having a bad time at home too, and they've slept bad, or they have problems with their wife, or their own father was dying, or there's all this stuff happening in your life. And then you have to be there for the patient, but you also take yourself with you to that conversation. So I totally recognize what you're saying, and this is a really important issue because you only get one chance to do it right. So if you want more information on that, you can contact me, and I can connect you with those Dutch people who do this, and they might know of people from English-speaking nations that might do the same kind of stuff. Yeah.
Fabulous, thank you.
Okay, well, thank you very much, and for those wise words to finish with there, Ian. we really appreciate you coming along and talking to us today, and to the audience for listening and for providing such positive feedback and such great questions. So just a round of applause from us all. Ian, I'll be in touch soon
Thank
to
you very
follow
much.
up, because I think there's plenty of opportunities for collaboration across the groups. And thank you once again.
All right, thank you very much. Have a great day.
You too. Thanks, everybody.